Thank you very much for that introduction, Andreas, and thank you for the invitation to speak here today, Christian. And welcome all of you this afternoon, and I'm sorry you had to see my skating picture as well. But it is true. That is the reason why there is a dance theme to this talk, and you will see that the dance theme will be woven through as we go through the whole presentation. And really good to see you have eating disorders on the agenda, so I'm glad to be introducing this to you today. So hip hop or Viennese Waltz, the complex dance of genes and environment in eating disorders. So here's an overview. This is where we're going to go. We're going to start with the disorders. For those of you who are less familiar with eating disorders, I'll briefly go through what the disorders are, talk about some myths about eating disorders that we need to bust, talk about what I consider to be the fundamental question that we need to address, talk about our cycle of risk paradigm that really had its birthplace here in Sweden, talk about genetic factors, perinatal factors, birth outcomes, childhood exposures, animal models, translational implications. I know it sounds like a lot, but it will all make sense when I put the model together. And finally, what does the title of this talk mean? So let's start with the disorders. We have DSM-5 coming up, and it's important that we just look briefly at some of the changes that are going to occur. So anorexia nervosa. Anorexia is characterized by low body weight, less than 85% of ideal, an intense fear of gaining weight, even when underweight, distorted body image, seeing oneself as large, even when one is emaciated, extreme focus on shape and weight, denial of illness, amenorrhea. It afflicts about 1% of females, and it is definitely more common in females than in males. What's happening with DSM-5 is that amenorrhea is going away. And this makes perfect sense, because most of the data suggests that there are absolutely no differences between people who have anorexia with and without the amenorrhea criterion. Anorexia has the highest mortality rate of any psychiatric disorder. And for those people out in the world who think that anorexia is just a passing phase, this is very important information to have, because people do die from this illness, and we need to really build our evidence base to decrease the mortality associated with anorexia. It's about 5% per decade of follow-up, with a standardized mortality ratio somewhere between 6.2 and 10.5. And suicide is very high. The risk of suicide is 56 times, almost 57 times more likely in someone with anorexia than in a healthy age-matched peer. And a BMI less than 13 leads to increased risk of sudden cardiac death. Some of you may recognize this is Isabella Caro. She was a French model who actually spoke out against anorexia nervosa, but died of a lung infection in 2007. Anorexia, for those of you who work with it or are afraid to work with anorexia, is a perplexing, intriguing, harrowing, frightening, and sometimes very frustrating illness. I've been fascinated with anorexia nervosa since 1982 when I first set foot on an eating disorders unit, and have been interested in trying to understand it and treat it ever since. Bulimia nervosa, the sister disorder, is marked by recurrent binge eating, which is eating an unusually large amount of food in a short period of time, coupled with a sense of loss of control. And that comes paired with compensatory behavior such as vomiting, excessive exercise, fasting. Also, extreme focus on shape and weight, somewhat more common than anorexia nervosa, 1.5 to 2%, and again, more common in females than in males. Binge eating disorder? The frequency criteria is going to go down. So in DSM-5, we'll be looking at once a week for 3 months in terms of how many times you need to do the behavior in order to have a threshold diagnosis. Binge eating disorder is that same recurrent binge eating, but in the absence of compensatory behaviors. People with binge eating disorder are often, but not always, overweight or obese. They're just stressed by the binge eating. It is more common. This is the most common eating disorder, afflicting about 3.5% of women, 2% of men. And the DSM-5 changes. The criterion is going to be once a week for 3 months, so becoming less frequent. And they're going to be adding the word regular in here, no regular compensatory behaviors. And the next disorder that we'll talk about today is EDNOS, or eating disorders not otherwise specified, of the purging type. And this is recurrent purging in the absence of binge eating. So compensatory behaviors such as vomiting or laxative abuse afflicts about 1.5 to 2% of females, although I hear it's vanishingly rare in Sweden. And it is also more common in females than in males. Let's start with some myths. And this really goes back through my history of work in this field. First off, families were blamed for causing eating disorders. We thought that controlling families somehow were at the root of these disorders. Ended up being just because these were the families that could make it to treatment, and frankly, few people thought about the impact that anorexia has on families, rather than that these family structures actually led to the development of eating disorders. Second myth, that anorexia nervosa is somehow a choice. And I think parents get trapped in this often, saying things like, why doesn't she just choose to eat? Or why doesn't she just choose to not binge? Well, it's not just a choice. And hopefully by the end of this talk, you'll have a greater appreciation of the genetic and biological components that contribute to etiology of anorexia nervosa. Third myth to bust is that anorexia nervosa is the province of white upper middle class girls only. This is a picture of a bunch of American debutantes who are being outed to the world. They are now free to be dated by gentlemen in the community, and this is the kind of clothes that they wear at their debutante balls. We know now that anorexia nervosa does not discriminate. It goes across the age spectrum, across sexes, and across socioeconomic stratus, and across all racial and ethnic groups. Society is to blame. Yes, society is to blame, however, not solely. And in fact, one of the things we need to look at is why the sociocultural myth has really persisted for so long. I'll talk about that in a few more slides. And finally, like just about every other disorder in psychiatry, the myth that mothers cause anorexia nervosa. Moms were to blame, again, for being over-controlling, and the belief somehow that the only way these young girls could get control of something was by controlling what went into their mouth. Again, mom is not at fault. If anything, moms and dads are our best allies in treating anorexia nervosa. The reason some of these myths have persisted is what I call the tyranny of face validity. And starting with blaming the mother and the family, we have gone through refrigerator moms when it comes to autism, thanks to Bruno Bettelheim. We have gone through schizophrenogenic moms, thanks to Frieda Fromm-Reichmann for schizophrenia. And not completely blaming Mnuchin, but a lot of it did start with his observations. We have blamed families for anorexia nervosa. In terms of society, I think this holds a certain face validity for the public because they see Twiggy. They started hearing about eating disorders around the time that Twiggy was popular. They see Kate Moss and Calvin Klein. They see the models on the runway. And there's a logical connection in their mind between this type of thinness and anorexia. What they don't see is the difference between Twiggy and this. They don't understand that anorexia goes so far beyond those societal portrayals of thinness to has gone far beyond where anyone would choose to go. But that is the tyranny of face validity. So the fundamental question that I'm interested in asking in the long term is this. For anorexia nervosa, you have ubiquitous exposure to societal pressures, but a rare outcome. So for the next 3 slides, I'm going to talk about the same group of 100 12-year-old girls. So you have that group of 100, all of them go on a diet. Most of them find that diet unpleasant. It's not something they enjoy at all. They want ice cream, they want something fun to eat. One, however, when she restricts her caloric intake, finds relief from her anxious dysphoria. This is the temperament that she was born with. But she, unlike the rest, finds dieting to be negatively reinforcing because it removes that negative dysphoria that she walks around with. It is also simultaneously positively reinforcing because the other 99 girls praise her for having lost weight. So you have this double reinforcement, negative reinforcement for removing the anxious dysphoria, positive reinforcement because societally it's always viewed as positive to lose weight when you go on a diet. That one girl out of 100 is the one who develops anorexia nervosa. Bulimia nervosa, impulse discontrol, but still an uncommon outcome. Same 100 girls. One of them is an early adapter. She tries smoking, she tries drinking, she goes on that diet, she might have some early sexual encounters. She also notices her tendency maybe to gain weight a little bit faster than her peers and is uncomfortable with that. She goes through puberty earlier. When she goes on that diet with her peers, her appetite breaks through. She just can't handle the dieting. She's impulsive and inhibited, and in the words of a very eloquent patient of mine, when she's at a party, she feels simultaneously like a wallflower and like she wants to dance on tables. So she has these two opposing forces inside her temperamentally at the same time. And she is the one, out of that 100, who goes on to develop bulimia nervosa. And then the third group, binge eating disorder, early manifestations and a common outcome. Same 100 girls, 2 already at this age are displaying loss of control eating. They might be taking cookies up to their bedroom. They might be hiding candy under their beds. They're both over the 100th percentile in weight. They too have gone through early puberty, and those are the ones who go on to develop binge eating. Now, we have not yet done the seminal prodromal studies that can say, who are these people? How can we identify them early and then go on to prevent the development of eating disorders? But from my perspective, this is the fundamental next question that we need to address in eating disorders research. In the meantime, what I'll introduce you to and walk you through is the cycle of risk paradigm that we've developed to illustrate how eating disorders travel across generations and through families. And this cycle of risk, again, was born in Sweden. And what we were looking at is that mothers with anorexia nervosa are more likely to experience labor and delivery complications and have children who are premature and small for gestational age. But we also know that prematurity and being small for gestational age are risk factors for the later development of anorexia nervosa. So we saw one mechanism whereby this might be perpetuated across generations. We, of course, have made it much more complex since then. So what I'm going to do is take you through 2 superimposed models, an anorexia nervosa model and a binge eating disorder model. Everything above the yellow line is pregnancy exposures, and everything below the yellow line are childhood exposures. So here's anorexia. So we start with anorexia nervosa, and then during pregnancy, we posit that mothers with anorexia may have experienced undernutrition and inadequate weight gain during pregnancy, which itself can lead to labor and delivery complications and babies that are small for gestational age. And then those children grow, and the issue is, during childhood, do we find that mothers with a history of anorexia engage in restrictive feeding practices, or if they're still suffering from eating disorders, might they be modeling maternal dietary restraint to their children? Now, a caveat. This is not a mother-blaming cycle. This is a way to break the cycle and to provide mothers with histories of eating disorders with assistance all the way around the cycle, which we will illustrate as we go through the talk today. The binge eating disorder cycle is a little different. We're going to start here with maternal binge eating. And during pregnancy, what we're positing here is that we'll see greater gestational weight gain in these women, nutritional dysregulation during pregnancy, and persistent binge eating while they are pregnant. That will lead to different labor and delivery complications, which include babies who are large for gestational age. And then during childhood, wondering and hypothesizing that moms may use food as a reward and that they might still themselves be suffering and again displaying binge eating in the home. So the children would be exposed both to genetic and environmental risk factors. So our goal then was to really unpack this cycle and do studies at each node along the way to illustrate and to look at the various hypotheses that we forwarded. So what I'm going to do is take you all the way around the cycle and talk about the different studies that we've done to address each of these nodes. We'll start with genetics, right there. Now, this is the history of psychiatric genetics and eating disorders, and a very quick presentation. First off, we know eating disorders run in families. If they didn't, there would be no reason to be doing all these genetic studies that we're doing. So the relative risk is about 10 to 20 for anorexia nervosa, and for binge eating disorder, about 2. What family studies traditionally can't tell us is why a disorder runs in families. To what extent is this due to nature? To what extent is this due to nurture? So we moved on to about a decade of twin studies, many of which occurred with the Swedish twin registry. And we know from multiple studies across multiple countries, all with European ancestry populations, that anorexia and bulimia are heritable. The genetic component is somewhere between 40 and 80%, and for binge eating disorder, about 40 to 60%. What twin studies have not shown us is which genes are operative and what they do, how they influence risk for eating disorders. So we moved on to some linkage studies. There have been 2 linkage studies conducted for anorexia nervosa, 1 for bulimia nervosa. We identified a locus on chromosome 1 that looked interesting for anorexia. We identified a locus on chromosome 10 that looked interesting from bulimia nervosa. But if you're a student of the literature, you'll have noticed that there haven't been a lot of follow-up studies from those linkage studies, and that we really don't have any genes in our pocket from those years of research that we did. Basically, linkage fell out of favor as an approach, and one of the large linkage studies never even got analyzed. So the data are just sitting there. And maybe we'll come back to this technique in the future. But for now, this has really sort of fallen from the vision of the eating disorders genetics world. We then moved on, like every other psychiatric disorder, to this parade of single gene candidate gene studies. And for a single gene candidate gene study, you need some a priori knowledge of the biology. You're predicting the same old genes, always a serotonin gene, a dopamine gene, an opiate gene. But as always, they're all underpowered. We have no replications, and we have no unique, reliable findings for any of the eating disorders from candidate gene studies. Doesn't stay this depressing. We then moved on now, and I'll tell you about an ongoing study, to genome-wide association. So we have 1 relatively small genome-wide association study completed, and 1 that we've just finished the analyses on. And after that, the next phase is going to be actually looking at gene expression and looking at epigenetic studies in anorexia nervosa. So that is the cascade of the history of psychiatric genetics and eating disorders. For today, we'll talk briefly about GCAN, or the Genetic Consortium for Anorexia Nervosa. Our goal in GCAN was to find unequivocal evidence of associations between DNA sequence variations in anorexia nervosa. And the primary GWAS was genotyping on female anorexia cases using the Illumina 600W quad array and ancestrally matched controls. And that becomes important when you see how many countries have participated in this study. Our cases were all DSM-4 anorexia nervosa or bulimia with a clear history of anorexia nervosa or EDNOS of the anorexia type. All samples had structured interviews or questionnaires based on DSM. They were all female participants, they were all European ancestry, and they all had biobanked and consented DNA samples. We were not funded to do controls. So we were in a very complicated position of having to find ancestrally matched controls for each of the countries that participated that were genotyped on similar platforms, which we did. The controls were not screened for anorexia nervosa, but given that it's a relatively rare phenotype, if anything, that's a conservative bias, so we weren't too worried about that. But we took painful care to make sure that these samples were very clearly matched ancestrally, so that any results we found were due to caseness, anorexia versus not, versus Finland versus Italy, or some other ancestral-based difference. So what we have is we had 15 different countries, samples from each. Sweden is represented. And we had to do individual analyses across these different 15 strata and then put them together in one large meta-analysis. Our uncorrected lambda for the preliminary analysis was 1.024. We had one SNP, which I will show you on the Manhattan plot in a minute, that exceeded genome-wide significance. And we are now following up 94 SNPs that have p-values of 10 to the minus 4. Now, the frequency and effect size are just what you would expect for common diseases like anorexia nervosa. And here is the Manhattan plot. And you can see this lovely little outlier significant SNP out there, which, as far as I am concerned, is a false positive until proven otherwise. So we're really doing everything we can to make it go away, because the chances that that really is a true finding are very low. But there might be something in here. Even though we had almost 3,000 samples, that is still a fairly small GWAS. So what we need to do is start pulling things together to increase our N with our replication efforts and some of the other efforts doing cross-disorder studies. So replication is currently underway with 3,000 independent samples and controls using sequenome. We're also looking at doing a GWAS meta-analysis with that other smaller GWAS that was performed that will boost our N up over 4,000. Looking at CNVs, doing a whole parade of pre-planned secondary analyses, digging deeper beneath diagnosis and looking at more of some of the symptoms or endophenotypes for anorexia nervosa to see if that might clarify results at all. But most importantly, and in my mind most interestingly, doing some meta-analyses with other psychiatric phenotypes and obesity. And the point of that is that DSM is unlikely to carve nature at its joints. So what we're really interested in is all of these disorders where there is some symptom overlap. We know, for example, from Swedish research, that individuals with anorexia nervosa over the long term show increased rates of Asperger's syndrome. So we also see a lot of social cognitive deficits in individuals with anorexia that suggest that they might at least populate some similar areas of that spectrum. We know there's a lot of overlap with obsessive compulsive disorder. 80% of people with anorexia have depression, and obesity is also an interesting phenotype to look at, not because I think obesity and anorexia are opposite ends of a spectrum, but because both have core components of weight dysregulation that could conceivably be influenced by similar genes. So this is where we're headed with the genetic component next, to see what comes out of the GCAN GWAS. I'm going to continue along the path of the cycle of risk to really go into pregnancy now. We've gone through genetics. We're going to go into pregnancy and look at this question of whether we have undernutrition and inadequate weight gain in women with anorexia, and whether we have greater gestational weight gain and nutritional dysregulation in binge eating disorder. So we're looking at perinatal factors. And this is when you know something is true. So there's a myth. The myth was that women with anorexia nervosa don't get pregnant. But in 2008, the New York Times dubbed the term pregorexia a buzzword of 2008. And once the New York Times says something's a real word, we all have to believe that it is a real word. So pregorexia, or being anorexic while pregnant, is now a real word in the dictionary. And of course, once they did that, there were just news flashes everywhere about pregnant women with anorexia and the impact that this has on their babies. So it became a thing once the New York Times made it a thing. But in the clinic, it really is an issue. So they were right. And in anorexia nervosa, we know from clinic studies and from case series that you do see inadequate weight gain. You see preterm birth, low birth weight babies, prematurity, increased risk for stillbirth, lower APGAR scores, and an increased cesarean rate. All of these are consistent with maternal undernutrition, but very few of those case series actually documented undernutrition in the moms during pregnancy. We also know that perinatal events increase risk for anorexia nervosa by 3.6%, especially prematurity and being small for gestational age, and that these findings are independent of sociodemographic confounders. To address these questions, we went next door to Norway, and we looked at the MOBA cohort, which is a birth cohort of 100,000 babies. And the babies are really sampled from all the way across Norway. The data timeline for the MOBA study is starting at pregnancy, 0 to 40 weeks, and they're sent an invitation at their 17-week ultrasound, and they complete questionnaires at 17 weeks and at 29 weeks. And then you're also assessed at the postpartum from birth to 6 months, and then later postpartum from 6 months to 36 months. And I'll be presenting data from each of these points as we go through the rest of the talk. In the initial cohort, and what we did with this study to really do some internal validation is we divided the cohort into two. And all of the studies we did looked at the first 50,000 as the test set, and then the second 50,000 as the validation set. And given that data collection was still going on when we did the first set, we're still in the process of validating a lot of the findings with the second 50,000. But for this first part that I'll present today, in that first 50,000, we identified 44 women with anorexia, 477 with bulimia, 2,706 with binge eating disorder, and 54 with that EDNOS purging type. Our first question was, what happens to eating disorders during pregnancy? Is pregnancy a transformational event? Does it give these women a new motivator for changing their behavior or really getting treatment? Or is it a period of increased risk for the development of eating disorders? So we wanted to describe patterns of remission, continuation, and incidence of the eating disorders during pregnancy. What we couldn't do is we couldn't, with questionnaires, look at anorexia during and after pregnancy, because it's just too difficult to assess low weight during pregnancy via questionnaire. But we did look at it for the other eating disorders. And what we found was that during pregnancy, if you compare the prevalence before and during, the prevalence of bulimia goes down during pregnancy in these women. The prevalence of binge eating disorder, interestingly, goes up during pregnancy. And this is clearly differentiating between just the ravenous hunger you get when you're pregnant sometimes and actually having an out-of-control binge. And the prevalence of EDNOS-P went down. When we looked closer, what we actually identified was 711 incident cases or new onset cases of binge eating disorder during pregnancy. And those cases happened to be in women who were surrounded by what's referred to as a matrix of disadvantage. So they were lower SES, they had less social support, less financial resources. So we seem to see that, at least for binge eating disorder, pregnancy appears to be a window of risk for the development of the disorder and the continuation of the disorder, whereas other disorders tend to remit during pregnancy. We also had an unexpected finding. And when we looked at the age of pregnancy in this cohort, we noticed that women with anorexia nervosa were having babies younger than women without eating disorders or women with other eating disorders. And we were perplexed by that, again, because of this myth that women with anorexia don't have babies and they don't reproduce. But yet it appeared that they were reproducing at a younger age. So we said, what could the cause of that be? And we went and looked, and we found that they actually had a much higher rate of unplanned pregnancies. And we went even deeper, and they had a much higher rate of induced abortions than women without eating disorders. Our guess is that a lot of the women with anorexia had either irregular menses or were amenorrheic, and they were engaging in sexual practices without using contraception. And we think, and we can always go back and look at this more carefully in the clinic, is that the take-home message is that anorexia is not a good contraceptive. And we know from other studies that people with anorexia do continue to have sex even when their libido is gone. So I think there's a public health message in here for physicians around the world that we need to be talking, even to young girls with anorexia, about birth control and making sure that they know just because they're not menstruating doesn't mean they're not ovulating and doesn't mean they're not at risk for becoming pregnant. So we went through that part of the pregnancy. Now let's look at what they're eating. Are they eating different foods, the moms, during pregnancy? And we didn't find any differences in the moms with anorexia in this cohort, but we did find differences in the moms with binge eating disorder. And as you can see on this slide, they have increased total energy, increased fats of all sorts, and lesser amounts of the good stuff, less likely to have folate supplements, decreased vitamin K, vitamin C, juice and fruit, and increased cakes, candies, milks, and desserts. This is all consistent with ongoing binge eating. but it is showing that there is nutritional dysregulation, or at least differences in the nutrition that the moms with binge eating disorder are getting during pregnancy. All of the women with all eating disorders had more of this stuff in their diet. So they all had more artificial sweeteners in their foods, in their beverages, across the board. So, the next thing, what was happening to their weight? Remember where we are in that cycle of risk. We're still on top, looking at the pregnancy exposures. This is about what's happening to weight gain during pregnancy. And here we have our different groups. The white group is the referent group. That's what the healthy non-eating disorders women are gaining between pre-pregnancy and birth of their baby. As you can see, women with all eating disorders, including anorexia nervosa, gained more weight, and gained weight more quickly than women without eating disorders. Now, this is the anorexia group. As you can see, they started a lot lower, but their weight trajectory was high and fast. So if anything, we're believing that this might be protective for them. So, for these women with anorexia, faster weight gain might actually be medically indicated and be protective for the fetus, so that they're not going through that period of undernutrition during gestation. For pregnant women with bulimia and binge eating, however, that increased and rapid weight gain might be more of a reflection of some of the ongoing disordered eating behaviors that they're showing even during pregnancy. So even though we might be seeing the same trends in the data, the reasons for some of those trends might differ across eating disorders subgroup. Let's look at what happens to that weight as soon as the baby comes out. And here's what we see, and this is probably no surprise. But the women with anorexia nervosa, they get that weight off as fast as they can. So by 6 months, they're almost back to exactly where they were before they had the baby. We are seeing a more quick trajectory. The women with binge eating disorder are actually losing a little bit more slowly than the healthy women. But I think the important thing of this slide is what we're seeing in the anorexic women. In that previous slide, they went up far and fast, and in this slide, they come down far and fast. So there we are, went through the top of that cycle, and now we're going to come over to this side and say what comes out the other end of the pregnancy. What are the labor and birth complications and delivery issues that these women encounter? So for the binge eating disorder cycle, what we're looking at is, are these babies large for gestational age, and are there labor and delivery complications? Here's our birth outcome slide. We'll start with the fact that there were no differences for anorexia, bulimia, binge eating disorder, and EDNOS-P on gestational age, on birth weight, on APGAR scores, or on mom's gestational diabetes. In terms of preterm birth, in the MOBA cohort, we actually saw less in the anorexia group. And for cesarean sections, we saw less in the anorexia group, but we saw more cesarean sections than the referent in bulimia, binge eating disorder, and the EDNOS-P group. And the anorexia and the EDNOS-P group also were slow to progress in their pregnancies. And this is interesting insofar as this is a replicated finding. In a study we had done a long time ago in New Zealand, we also found slow progress in women with anorexia who were pregnant as well. I don't know what the hormonal mediator of that might be, but it is intriguing that it popped up twice in 2 independent samples. So I'll be interested in your thoughts when we get to the question and answer period about whether you can think of a mechanism for why this might be occurring. In binge eating disorder, we did find they have larger babies. So they're continuing to binge eat during pregnancy. You saw what their nutritional intake was like, more fats, more energy, more binges. So they're at increased risk for having babies that are large for gestational age, which is probably directly related to why they're at increased risk for needing cesarean sections. So let's sum up what happened in the top of that cycle of risk. First off, pregnancy does appear to be a window of remission for some eating disorders, especially bulimia and EDNOS-P. Pregnancy does seem to be a window of risk for another eating disorder, for binge eating disorder. Anorexia nervosa in the MOBA, from what we can tell, is less severe than the anorexia that we're seeing in the clinic. And I think this is just a sampling bias. I think these women are healthy enough to participate in MOBA, which takes a lot of energy to participate in, and they're also healthy enough to have become pregnant. So there's definitely a difference between the anorexia we're seeing in this sample and the anorexia that we're seeing in the clinic. So bear that in mind when you look at the data. But what we are seeing are clear deviations of maternal weight trajectories and maternal nutrition across multiple eating disorder presentations in the MOBA sample. So let's take it one step further. We're going to go down below the yellow line and start looking at some of the childhood exposures. And we'll start with breastfeeding. So we'll also go one step further and look at whether the moms are using food as reward for binge eating disorder. Starting with breastfeeding. So this is our non-eating disordered group, and what we're looking at is week 1 and then month 1, 2, 3, 4, 5, and 6 in Norwegian. And as you can see, brilliant. From an American perspective, it's just so amazing to see this many women starting breastfeeding and how long breastfeeding persists. We would give anything to get those rates in the States, where at home it's much more like 65% as a starting point. And then in comparison, what you see, we'll start with women with bulimia nervosa. They start, but then it starts dropping off. Binge eating disorder similarly. But then when we start seeing anorexia nervosa, you see much more rapid decrease in breastfeeding as you're 6 months out, and EDNOS-P even further. So women with anorexia nervosa and EDNOS-P are having difficulty sustaining breastfeeding throughout that first period of life, with the recommendation being at least 12 months. By 6 months, you're already seeing considerable falling off at that point. We also wondered, once they do start doing regular food feeding, are there differences in the ways in which they feed their children? So our hypothesis was that we might see more using food as a reward, or we might see more restrictive feeding patterns in some of the different eating disorders groups. What we found, contrary to what we hypothesized, because we thought if any moms were going to be the restrictive feeders, it might be the moms with a history of anorexia nervosa. What we found was that moms with bulimia nervosa and binge eating disorders were the ones that were more likely to restrict their children's food intake. And what we know from other studies that weren't self-report when we've actually done focus groups with moms is that these moms have such a fear of their children developing dysregulated eating that they hold back on feeding, hoping not to develop binge eating in their children. So there's a lot of thinking in these moms about what they should do in the feeding situation to keep their children from developing the eating disorders that they suffered from. But again, in the anorexic group, we did not see this sort of restrictive feeding. What we did see in another study in women with histories of anorexia was moms taking special approaches to feeding their children. So this was more organic foods, less processed foods, only foods that they made in the home, no foods that came in jars. So there's clearly a lot of attention being paid to what they're feeding their children. And again, untangling that from ongoing eating disorder symptoms is a challenge. What we do know is that these moms are so desperate for intervention. I'll talk about this a little bit later, but I'll bring it up now because it's relevant. We developed a program called Nurture, which is it's a psychoeducational program for moms with histories of eating disorders. It's the only treatment trial I've ever done that has 0 dropout. These women are just desperate to learn more about how to nourish their children well and to do whatever they can to buffer their kids from going on to developing eating disorders as they mature. So it is a population that is hungry for intervention, that is just ripe for us to go in and break that cycle of risk while they're actively feeding their children. All right, so I'm going to take you one more step around, and what we're going to look at now is we're going to start looking at food as a reward and some work on adolescent exposures. So we're moving across the developmental spectrum, and we're also moving across species, because I'm going to start going into a little bit of rat work now to start showing what's going on during adolescence with binge eating. And these are our animal models. And basically what we're looking at is we're looking at binge eating and dopamine in rats. And this is ongoing work from Wendy Mathis, who's a junior faculty member with us, Danita Robinson, Fulton Cruz, who's an alcohol researcher, and myself. And what we're interested in is critical developmental windows for the emergence of dysregulated eating. And also looking at gene expression and when gene expression occurs. Now, this up here is a very famous American cookie. It is an Oreo. And rats love Oreos. It is just by far their favorite binge food. So all of the work that you will be seeing, and I'm not funded by the Oreo company, so there's no disclosure that I need to make, but all of the work that you're about to see has to do with how excited rats get about Oreos. And I'm going to show you a little video. And what we know and what we have found is that binge eating is associated with changes in dopamine signaling in the rat. And we're going to talk about some phasic dopamine release in the next slide. But what I'm going to show you here is what happens to a little rat who has had previous Oreo exposure. And our question was, how can we pull apart their excitement, and yes, I'm anthropomorphizing, but their cue reactivity to the Oreo without activating their sense of taste? Because we didn't want to know what was happening to dopamine when they were eating the Oreo. We wanted to know what happened to dopamine when they were anticipating the Oreo. So this rat had previous exposure, and this is what it does when we take an Oreo, and it's a little mean, but not too mean. We crush it up, and we put it in a metal tea ball. You know what you make your tea out of? And so the rat can smell the Oreo and knows the Oreo's in there, but we don't get it too frustrated because we also didn't want to be measuring rat frustration. So here's the excitement that you might see in a rat who knows what's in the tea ball. It wants in. It wants the Oreo. In fact, we have had 2 of them actually get it open. So they are so excited by the presence of that Oreo that they have managed to get the tea ball open. So what you're going to see in the next slide is we put little holes in their head, and we put electrodes straight into their nucleus accumbens, and we measure phasic dopamine release during different phases of introducing this Oreo into their cage. And let me show you what we have here. So what's going down on the bottom is it shows you the phases of exposure. So this is the little rat just in the cage hanging out with a thing coming out of its head. This, you can see the researcher's hand coming in, putting the Oreo in the cage. Here it is, just doing its thing with the Oreo, and then it's happy. And here is the tracing of the dopamine transient. So you can see when that hand goes in there, immediately thereafter, that dopamine spike goes awooga. It gets excited when it smells that Oreo. So what we're seeing is we're seeing this transient dopaminergic response to a yummy cue when introduced. What's interesting is that after you do this a couple times, you don't see these dopamine transients anymore. So it appears to be something that is unique to the acquisition of this behavior. Once it's established, they're like, oh yeah, another Oreo, that's kind of good, but you don't see the same kind of excited firing. And what we wanted to know is then, okay, what is it and when does this behavior get established that these dopamine transients really do start firing and increase their risk for subsequent binge eating? So with my developmental hat on, I'm always interested in critical windows and when do these things actually happen that can lead to a lifetime of disordered behaviors. And as an adolescent psychologist, I'm particularly interested in adolescence because we know that all sorts of high-risk behaviors start during the adolescent period. Smoking, drinking alcohol, piercings, all sorts of things happen. It's a time when so much is happening developmentally in the brain, and so many unhealthy behaviors are becoming acquired. So what we did is we took some adolescent rats, and what we did was we trained them to binge eat using Oreo cookies again when they were adolescents. But then, the mean mothers that we are, we took Oreos away as they were developing. So they had that exposure, but then they went through a period of deprivation, which, as we know, in adolescents when they go on diets, happens quite frequently. But then what we did is we reinstated the Oreos when they became adults again. And we wanted to see what was happening to gene expression during that period and what happened to taste preference. If they were exposed as adolescents and then taken away so that they didn't have access, was there some sort of memory and some sort of excitement that was still associated with the Oreo cookies? The first thing we did was just look at sucrose preference when we reinstated the sweet taste things when they were in adulthood. And the top line here is the group that had been trained to binge when they were adolescents and then deprived. And as you can see, later, when they're adults, just across the board, they have that higher sweet taste preference than rats that had not been trained to binge eat when they were adolescents. So something changed through that adolescent exposure that was then expressed in adulthood. The next thing we did is we looked at gene expression in their hypothalamus and in adipose tissue. And this is not replicated yet, but I wanted to give you some hot off the presses stuff because this is really interesting. So when we look in their hypothalamus, what we're seeing is that dopamine transmitter gene is expressed twofold in those rats, in the hypothalamus of the rats who were trained to binge eat when they were adolescent. So we're seeing changes in the brain. If you expose these guys to Oreos, train them how to binge when they're adolescents, abstain, and then give it back to them when they're adults. We're also seeing changes in adipose, and any of you interested in cytokines, we might be seeing some very interesting changes that's actually going on in fat and in adipose in these animals as well. So more on this to come. Stay tuned to this channel. The next thing that we're going to do is I'll tell you what we're going to do. So the next thing we're going to do is we're going to be feeding the moms when they're pregnant a high-fat diet, because adolescence is interesting, but I'm even more interested in what's going on with our binge eating disorder moms. You saw in that previous slide that they have increased fat intake, that they have increased candy intake, that they have increased energy intake. Are they setting their kids up in adolescence for having higher sweet taste preference and more likely to binge? And that's what we want to look at in the rats. So we want to look at the impact of maternal high-fat diet in the dams during gestation and see if that influences binge acquisition, sucrose preference, and gene expression in their offspring. All right, so have I shed any clarity on this cycle of risk that I started out with? And let's just go back to the cycle of risk, go through it again, and see what we've learned and what we haven't seen. So we started off with genetic factors. And, did we have a whoppingly exciting genome-wide association study to report here today? No. Is it a completely null GWAS? No. Do we have more work to do? Absolutely. And where's the money going to be? The money is probably going to be in those cross-disorder studies where we really stop carving nature in funny ways and pull things together across different psychiatric and medical diagnoses. When we look at the BED cycle, yep, we saw it. We saw greater gestational weight gain. We definitely saw nutritional dysregulation and binge eating during pregnancy in these women. When we come around to the anorexia cycle, in this sample, we did not see undernutrition and inadequate weight gain. In fact, we saw the opposite. We saw rapid and high weight gain in women with anorexia nervosa, different from what we see in clinic samples. We did not see small for gestational age babies in anorexia in MOBA, but we do in the clinic. And in MOBA, we did see babies that are large for gestational age in offspring of women with binge eating disorder. In the anorexia cycle, we saw that these moms are engaging in selective feeding, And one of the things I didn't mention, but is very interesting, is we're also seeing increased parenting stress in these moms. We've done some interesting vagal tone studies on the moms during the feeding situation, and they are showing much higher stress during feeding than women without anorexia nervosa. We have not shown maternal dietary restraint because we didn't look at it, but if we go to the BED cycle and our animal work, we are showing food as a reward and that adolescent vulnerability period, and we are seeing that the moms with binge eating disorder are engaging in restrictive feeding practices. So let's see what this means. I'm a clinician. I run an eating disorders program. I like taking this work, bringing it into the clinic, and figuring out how can we use this information now. A, can we use this information now? And B, how can we use this information now to help patients today and families today? We can't do much with the genetics yet, but I think there's enough data here to suggest that perinatal screening for eating disorders is intelligent. I think we've gotten much better, at least in the States, at screening for perinatal depression. We do not routinely ask about eating disorders at all. It's not on the checklist that you fill out when you go in for your obstetrical appointments, and it should be. Part of that has to do with all those myths that I started out with. There's still stigma associated with having an eating disorder. Most of our patients will say that they're so frightened about being weighed when they go in for their prenatal appointments that they will restrict for days before they go in so that their weight doesn't show increases. So our medical practice is actually fostering some of the behaviors that can be putting their babies at risk. So we really need to work with the obstetricians to make this something that can be discussed so that we can screen and help these women at the time. Second thing, the type of help they can get. Clearly, the data show that dietary counseling is important throughout pregnancy. This needs to be addressed, both on the binge eating disorder side and from what we see in the clinic on the anorexia side. Psychotherapy during pregnancy. In the clinic, women with anorexia say this is one of the most terrifying things that they have ever gone through because their body is out of their control. They're afraid of gaining weight. They don't know how much weight to gain. They don't know what's normal. And I think, as reflected in the breastfeeding data and in the weight data, as soon as that baby's out, their reason for eating and for gaining weight is gone. And then we see a rapid return to exercise. We see that drop off of breastfeeding. So they need support throughout pregnancy and afterwards to maintain healthy behaviors to give their kids a strong start. Parenting interventions, as I mentioned, like our Nurture program, has been so well received by moms. They don't know what a normal portion size is. They don't know what to feed their children. And most interestingly, when they look at their babies, they don't know what's normal and what's fat. And part of it is wondering whether some of the distortion they have about their own body image is being projected onto their babies. But the good thing is, the beautiful kernel here is that they're worried about that and they want help. They don't often talk to the pediatricians about the fact that they have a history of an eating disorder, but if they could, it would facilitate that conversation and be able to intervene and help them judge their children's developmental trajectories more effectively. Early detection. I can't tell you how often people come into our clinic and kids come into our clinic when they've reached weights that are so low that we know it's going to take months in order for them to refeed. If we can detect eating disorders earlier, again, fighting some of this stigma, and working with the moms who have histories of eating disorders, we might have better outcome data than we currently have. Same thing with early intervention and building the evidence base. We've done good work. This has not been a treatment talk, but we've done good work in developing the evidence base for children and adolescents with anorexia nervosa. We've done a very bad job in developing the evidence base for adults with anorexia nervosa. And what we've seen is a complete shift in the demographic of presentation. In the past, we did see a higher percentage of adolescent patients who were coming in for treatment. And now that curve is broadening out. We're seeing more prepubertal patients, and we're seeing more people in midlife and beyond. So it's flatter, and it's going across the age span. So we really need to work on those two bookends, on the prepubertal patients and on the midlife ones, in order to build the evidence base to treat them more effectively for anorexia and for bulimia and binge eating disorder. And one of the things that we've done is we've developed a couple intervention that really leverages the power of the partnership in much the same way that family-based therapy leverages the power of the family in treating anorexia nervosa in kids. So I think focusing more on the family as a solution than focusing on the family as a problem is really going to help build out that evidence base and lead to better outcomes. Next step, continue populating this model. We're going to keep working through this cycle, building up those different nodes and understanding and learning how to break the cycle of risk. We're going to enrich the biological components and follow these kids as they enter the age of risk. The oldest MOBA kids now are 9, so they're entering that very interesting age where we might be starting to see the beginning of some disordered eating behaviors. Look at this from a fetal programming perspective. How is that maternal nutrition influencing some of these kids' later weight and growth and sucrose preference, for example, trajectories? And incorporate in that model genes, all relevant environments, and developmental factors. And now, probably even forgot what the title of the talk was, but I started out posing this very important question of, is eating disorders research more like hip hop, sort of exciting but somewhat inchoate and all over the place, or is it more like a Viennese Waltz where we're starting to see patterns and rhythm and a future? And I'm not going to make you vote, but I'm going to show you my answer. Seems to whisper your name. Don't know why I waited to tell you before. These say the passes. I just love you more. I can't tell you how long it took me to find a Viennese Waltz that actually went in a cycle, like the cycle of risk, but I found one. So I actually do think that we are heading more towards a Viennese Waltz than hip hop. So thank you very much.